Hey everybody, welcome to Pick Dr. Osborne's Brain. Got a great show for you tonight. We're going to be talking all about autoimmune pain, including some of the major triggers. We're going to be getting into gluten sensitivity tonight, but also some of the other triggers for autoimmune pain. But stay with me all the way to the end. We're going to be talking about how medications can cause leaky gut, which ones to watch out for. I'm also going to be giving you some of my best and top strategies for nutritional if you will, nutritional hijacks around pain, like some things you can do to support your immune system inflammation so that you have to worry a lot less about inflammatory pain and you can worry more about enjoying your life and being functional. So before we get started tonight, make sure you tell me hello. Tell me where you're tuning in from in the world. So drop a note. Make sure to drop a heart, drop a thumbs up for me. The more of those you give me, the more this information reaches a larger audience. So make sure you're doing your part. Help me get and reach more people. Hashtag save 100 million lives. So let's dive in tonight. We're going to be, again, addressing in a big way gluten and pain, because gluten is a major contributing factor to autoimmune pain. But let's talk a little bit about some statistics first. So what we're looking at here, this is a projection of the cases, and this is U.S. projections, right? So arthritis will increase as the population grows and ages. But here are again, this data is from 2015. So you can see here, this is where the data is accurate, but this is the future projection as it goes forward into time. So right now, as it stands, about 25% or 1/4 of the population has some degree of inflammatory arthritis. So that's 54 million people. Now, 66% of that 54 million are women. So we look at this number again, that 54 million, 2/3 ladies, that's you. 2/3 are ladies, 1/3 are guys. So I know a lot of times, men will let things hurt until they fall off. You probably experienced that, ladies, if you're married, your husband won't go see a doctor until something falls off or breaks completely. But women tend to be the ones that are most affected. And so again, this is coming from research studies that have been conducted in the US. And one of the reasons why I personally think we see women more affected than men is, number one, as it relates to autoimmune disease, we know that women are more affected by autoimmune disease. There are some hormonal differences between men and women that predispose toward the progression of autoimmune disease. But one of the other reasons why I think we see more women than men being affected has to do with the fact that men just don't want to go see a doctor again, and not until it falls off, not until it breaks. So women tend to go visit the doctor more frequently. Now, that being said, we got 54 million people who are predominantly addressing pain through pharmacy, right? So polypharmacy or multiple different types of medication. So what I call the prescription pain trap. And the reason why I call it a trap is because we have to understand that, philosophically speaking, drugs don't solve why pain is there. Drugs simply suppress or mask the pain. They mask your body's ability to interpret the pain, or they suppress the inflammatory chemicals that are designed to create the irritation that leads to the perception of pain. And so that's pain medication. So whatever class we're talking about, the problem here is, and it doesn't matter which class you're talking about. So like let's just put in some examples here. So if we've got non-steroidals, NSAIDs, okay, that would be things like ibuprofen, meloxicam, Celebrex, aspirin's a non-steroidal anti-inflammatory. Then you have steroids. So that would be like your prednisone. Then we have the narcotics or the opiates, a little bit stronger. And then we have other special types of medications or specialized types of drugs, like, for example, one of them is called gabapentin, if you've ever taken that for neurological pain, because we're not just specifically talking about, specifically talking about joint or muscle pain, but we're also tying in neurological pain. They all kind of three go hand in hand. And then, of course, there's also what many people take, and that's like a Tylenol or acetaminophen. Okay, these are all just different, what we call the vast majority of options from a let's block it perspective. But every single one of these, except for Tylenol, so no GI symptoms. But the other ones all alter GI function. Now, why is that important to understand as we're talking about pain is when you alter GI function, you alter your nutrition. And when you alter your nutrition, you create a scenario biochemically where you're less apt to heal, repair, restore, and recover the inflammation. And so you can see it'll alter GI function, and I'll get more into depth about that, but that can lead to nutritional deficiencies. For example, Tylenol causes glutathione deficiency. Maybe it doesn't alter your GI function, but it does cause glutathione reduction. Glutathione is how we detoxify. It's how we take out the trash. Opiates and gabapentin, these all lock your gut up, creating severe constipation. Steroids and NSAIDs, these can cause ulcerations in the stomach and small intestines, leading to a host of problems, but leaky gut being one of those. And if we're talking about autoimmune pain, remember that one of the precursors to autoimmune pain is leaky gut. So if the solution to the pain actually leads to enhancing the ability for the pain to be recreated in different ways, then it's not really a solution. The other problem with NSAIDs, you can get folate, iron, and vitamin C deficiency. So these can all come back low as a result of long-term NSAID use. Steroids will deplete vitamin C, they'll deplete calcium, they'll deplete magnesium, they'll deplete vitamin D. So you've got problems nutritionally with these two classes, the NSAIDs and the steroids themselves, and then that can't find me somebody who's going to be able to heal when they're in a situation where they have a vitamin C deficiency. Vitamin C is critical for healing and repairing inflamed tissue. It's one of the inflammatory modulators of the body. It's just one of the most important ingredients used in that aspect. Folate, in this case, in this example, folate is necessary to form new cartilage. So if you've got arthritis and your cartilage is damaged and your body's trying to heal or repair that cartilage, and you are taking a drug that blocks the pain but also inhibits your ability to reheal your cartilage through folate deficiency, guess what? You're not getting any better. And so that chronic persistent illness maintains itself. And so then usually what happens is let's find a different drug, or let's find a new drug, or let's kind of start combining drugs. This is what I meant by polypharmacy, more than one medication. Now, aside from the prescription pain trap, we look at this image here. So let's just blow this up. You can see here, talk about this a lot in No Grain, No Pain, but grains lead to death by medicine. And what does that mean? So here's the myth. Grains are a necessity for a healthy diet. The fact is grains and the chemicals found in grain-based products can cause a leaky gut and inflammatory pain. Doctors treat the situation with pain medicine, as I've just kind of laid out for you, and the pain medications can cause leaky gut and inflammation in the intestine. Even worse, pain medications are estimated to kill 16,500 people a year. Now, this is opiates. So we're talking about opiates. We're talking about narcotics, right? If we're talking about Tylenol or aspirin, predominantly non-steroidal anti-inflammatories, we can add to this another 13,000 deaths, and this is just aspirin. You guys maybe didn't know that, right? Aspirin kills about 13,000 people a year when properly used, and that's an over-the-counter medication. So a lot of people think of aspirin as this inert, non-dangerous medication, but for many people can become very, very problematic. If you want to go read more about those things, I've got the references in there for you. But again, going back to the theme, which is grain-induced inflammation, can lead to chronic pain, autoimmune pain, which then leads doctors to want to prescribe medications. And the medications themselves, if we combine just these two types of medications, aside from creating altered GI function, nutritional deficiencies, inability to heal, and chronic persistent illness, again, a lack of a solution, what we actually also get is about 30,000 deaths a year on top of it. Now, I know some of you may be saying, yeah, but my quality of life is so much better when I take that pain medication. So I would just ask you to consider some of these things I'm about to talk about. Your quality of life, your perceived quality of life through pain might be better, but look at some of the side effects. So these are different classes of medications, and just going to kind of go through this diagram with you, but drugs that cause gut dysfunction. And so not all drugs that treat pain cause gut dysfunction. In essence, other drugs can create gut dysfunction as well. Many drugs are kind of what we would call an equal opportunity gut destroyer, right? So as we look at kind of some of these things, so in the mouth, we've got pain and anti-inflammatory medications can cause the gums to bleed. So in the mouth, pain medicines can cause bleeding gums, which means you're starting to see your gum line erode, which means your dentition is going to suffer, which is going to make you more susceptible to malnutrition over time, because as your gums are bleeding, you're more apt to lose your teeth. The tongue, we've got antacids, antibiotics, hormones, anti-inflammatories, diuretics. This is if you're on blood pressure medications that are diuretics. Antiviral drugs, so those of you that might take a drug for like a herpes outbreak or mouth sore outbreaks. Blood pressure medicines, allergy medicines, cholesterol-lowering drugs, and antidepressant drugs can all alter your ability to taste your food. Now, one of the fundamental problems with altering taste is people change. We'll just use a triangle for that means delta. That means change, right? They change their diet. Typically, they increase sugar and salt, because the altered change is a reduction in the ability to perceive taste. Okay, so when you can't taste, you tend to add more things that add taste to the food. For most of us, that's sugar and salt as a byproduct of that. Now, one of the reasons why these different classes of medications oftentimes alter taste, not all of them, but one of the main mechanisms of altered taste is a reduction in the mineral zinc. Many of these drugs affect your body's ability to digest, absorb, and to assimilate zinc. And zinc is very critical in both our ability to smell and taste. So lack of zinc can lead to gustatory problems or tongue problems or taste issues. And so that can be an issue. The gallbladder. So the gallbladder is part of our GI tract, even though it's not classically considered our GI tract. You kind of look at your gallbladder right here. It's that little sac right next to the liver that secretes bile into the small intestinal area, which starts right here in this little section. So that small intestinal area, the bile is what helps you to digest and absorb fat. So that's vitamin A, vitamin D, E, and K, omega-3 fatty acids, all critical. And if we take medications that affect the function of the gallbladder, so one of those is hormone therapies like estrogen. Okay, so it's a side effect that many doctors fail to discuss with their patients. Cholesterol-lowering drugs can affect the gallbladder, especially what are called bile acid sequestrants. Not so much your statins, but bile acid sequestrants, which are drugs that bind onto your bile, or that affect your bile, and so therefore make it harder for you to produce it. And it can, again, it doesn't change your gallbladder, but it changes what your gallbladder is supposed to do. Then we have drugs that affect the liver. So one of the predominant drugs that affects your liver function is Tylenol or acetaminophen for pain. So a lot of people take the drugs for pain, the Tylenol for pain, not knowing that it actually depletes the liver of glutathione. And then there's anti-inflammatory drugs, cholesterol medications, antiviral drugs. They can all cause liver dysfunction. And the more that you're on, and this is what we generally tend to see, so arthritis or pain is more common it increases with age. And so what also increases with age is the amount or the quantity, the number of meds increases with age as well. So we've got arthritis increases with age, and number of meds increase with age. And number of meds, the more you take, the more it impacts the liver. So again, as you age, if you're taking more medicines, the more you impact your liver, the more susceptible you're going to become to drug side effects, which is part of what we're talking about here. We also have drugs that can slow down or hinder digestion. As a rule of thumb, antibiotics, antacids, pain, and anti-inflammatory drugs. You see these are making kind of waves in a lot of different areas here. And then gas, bloating, diarrhea, constipation can occur with the use of antibiotics, antacids, laxatives, hormones, blood pressure medications, diabetic medications, cholesterol-lowering drugs, and antidepressant medications. So that's almost every major class of drug that is a common kind of tool in the toolkit of most doctors today. So you go to the doctor, there's a pretty strong likelihood you've been given something in that realm of medications. All can potentially impact your ability to digest and absorb. And then we've got on the other side of this equation, we've got drugs that can affect the salivary glands like chemotherapy. So if you've ever gone through conventional cancer treatment, these drugs can affect your ability. They can damage your salivary glands and hinder your body's ability to secrete. Salivary glands help with digestion, but they also help you to secrete IgA. What is IgA? IgA is your primary antibody. It's your first line of defense antibody. You make it in your saliva, and these medications suppress that. So it can make you more susceptible to infection, among other things. You don't want to have dried out salivary glands that aren't secreting IgA. Your esophagus, pain medications, anti-inflammatories, antibiotics can cause pain with swallowing, which can lead to the inflammation of the esophagus. And then we've got drugs that affect the stomach, like chemotherapy, anti-inflammatories, antibiotics, acid reflux medications, antidepressants, hormone medications. All these have been shown to damage the lining. So the lining of the stomach gets damaged or can be damaged with these different types of medications. And then drugs that affect the pancreas, predominantly anti-inflammatories, antiviral, and pain medication can cause indigestion and inflammation of the pancreas. And then the small intestine, kind of the same group of drugs that affect the large intestine. So again, your antibiotics, your anti-inflammatories, your oral contraceptives can interrupt absorption and digestion. Now, I did a whole show on estrogen and leaky gut a couple of weeks ago. If you didn't watch that, you might want to go back and watch that. This is part of some of the things that I'm talking about. But most of your medications, my point is, most of your medications cause gut dysfunction, right? Or liver dysfunction, which makes you more susceptible to the increasing number of medications that doctors generally want to put you on as you age, as you become symptomatic. The key here is that don't buy into the thought that just because you're aging that you're somehow supposed to be on more medications. Look, a lot of people that come to see me, they'll follow through with their doctors, and their doctor, when they're not on any medication, the doctor say, what are you taking? And they'll say, I'm not taking anything. And they may be in their 60s or 70s, and the doctor's jaw hits the floor like, how could you not be taking any drugs? As if your body is so broken and so fragile that without the drugs, you're somehow going to die or not be able to function. This is a common misconception and myth. So again, remember, why are we talking about this as it relates to pain? Because many of you are on medications, and whether you're taking medications for pain, okay, which again, alter GI function, nutritional deficiencies, inability to heal chronic persistent illness, or whether you're taking medication for some other reason that's not pain-based, you can actually still create the GI dysfunction, which leads to the nutritional depletion and to the other damage to your liver and other organs, again, that can affect your body's ability to heal and repair itself. So moving on, some of the other things, again, if we kind of a continuation of that last diagram, drugs can alter taste and smell. They can disrupt GI motility, causing constipation and or diarrhea. They can cause nutritional deficiencies. They can cause you to have an increase or a decrease in appetite, which can lead to weight loss and or weight gain. And if we're talking about chronic arthritis, we certainly don't want to see you gaining weight, putting more pressure on those joints. So remember, medicines don't come without a price. You just have to ask yourself if you're willing to pay that price. Is the risk of the side effect of the medication worth the benefit that that medication might provide? Or have you just ignored the fact of the matter that if you change your diet and change your lifestyle, you could, for the most part, alleviate the vast majority of your pain and not have to worry about polypharmacy as even a viable solution. So next, let's look at this, talking about leaky gut. So pointing out here, the reason why I keep bringing this up is because leaky gut is a precursor to autoimmune disease. And as I said earlier, autoimmune arthritis are quite common, And so if we have something called leaky gut that we know this can cause or contribute to autoimmune disease, and we certainly want to know what causes this leaky gut. And so again, looking at one of the main classes of things that causes leaky gut is right here. It's medicine, medication. So don't fall into that pain trap, right? Don't fall into that prescription pain trap, because if you are gluten sensitive and your symptoms are pain, autoimmune pain, and you're being medicated because of it, you're trading one aspect of leaky gut for another aspect of leaky gut, but you're still not solving the root problem. You're not solving the real reason why the gut is permeable in the first place. And so when you mask or when you mitigate symptoms through artificial chemical manipulation without actually ascertaining why the symptoms exist, what you're serving to do is lie to yourself. And progress doesn't happen with fibs or with lies. Lies only lead you to kind of down a path of persistent issues or new problems. Okay, let's talk about next autoimmune pain and arthritis. So what are some things that we know about, or at least some conditions that we know about as they relate to gluten? Now, I really want to focus and talk about gluten now. So this list, this diagram, autoimmune pain and arthritis, these are conditions related to gluten, meaning we either know gluten can contribute to these different diseases or we know that gluten can directly cause some of these different diseases. So rheumatoid arthritis, juvenile rheumatoid arthritis, psoriatic arthritis, lupus, reactive arthritis, migratory arthritis, fibromyalgia, dermatomyositis, ankylosing spondylitis, scleroderma, Raynaud's phenomena, neuropathy, reflex sympathetic dystrophy, or RSD. These are all just examples of chronic pain conditions that are autoimmune in nature that can either cause joint autoimmune disease or neurological autoimmune disease that typically get treated predominantly. There's kind of two main. We look at how do doctors treat this? So treatment is typically steroids or biologics. In some cases, what are called DMARDs, disease-modifying anti-rheumatic drugs, is what that stands for. These are drugs like methotrexate. Okay, so this is pretty much what people get offered, right? And we know that methotrexate destroys the gut. We know that steroids destroy the gut. We know that biologics destroy the immune system and increase your risk for the development of infection and cancer. So you're either left with these options to control or mitigate your pain, or you're left with identifying why these diseases exist. And so we look at, okay, what causes these things? We know that gluten can. If this is the first time you're hearing it, welcome to the club. If this is not the first time you're hearing it, great, let it sink in, because here's what I see in my clinic time after time after time. People come to see me with all these different types of conditions, and they're not following a gluten-free diet. They've even read my book. They've read No Grain, No Pain. They're like, well, I read about, gluten can cause rheumatoid arthritis, but nobody ever said anything about scleroderma, or nobody ever said anything about ankylosing spondylitis specifically. So I want to be real specific tonight. If you see the condition on this list, then you should know that there's research, both anecdotal and clinical, as well as broad spectrum studies published in the medical literature that show the connection between gluten and every one of these conditions that we're talking about on this list. Now, I got another diagram for you because I think there were a couple of synonyms and things of that nature. So you're going to see some repeats here, but this was just 10 forms of muscle and joint pain caused by grain or gluten specifically. And so you'll see some overlap here, but you'll also see some new things showing up. There's some medical references. If you really, really like to read and you want to learn more, you can go track down those references. These are all from No Grain, No Pain. But what I'm showing you here now are just a few of the references because there are literally thousands of references on this topic, but I wanted to show you just some highlights of some things. So this was published in Rheumatology Clinics, and you can see the conclusion here, and this is about rheumatoid arthritis. It's possible that celiac disease may be the correct diagnosis in a patient with polyarthritis. What does polyarthritis mean? That means arthritis affecting multiple joints. Polyarthritis is kind of sometimes a synonym for reactive arthritis, sometimes a synonym for rheumatoid arthritis. Even if the patient meets the ACR criteria for rheumatology or rheumatological arthritis or rheumatoid arthritis, there we go. In other words, celiac disease should be considered among the differential diagnosis in a person with polyarthritis. In other words, if somebody has autoimmune arthritis, gluten, which is what celiac disease is, celiac disease is the intestinal manifestation of gluten sensitivity. Now, on that note, I think it's important to bring this up. There's the term celiac disease, and then there's another term, non-celiac gluten sensitivity, NCGS. This term, non-celiac gluten sensitivity, was created because a lot of people, even though they have a positive biopsy or they have the blood work that might match celiac disease, they never get a diagnosis of celiac disease. And why is that? Because celiac disease, in medicine, it's thought that it affects the GI. So what do we see? What is a classic training in medical school is celiac patient presents with diarrhea, with weight loss, and intestinal symptoms. Okay? The reality is a person can still have gluten sensitivity. Again, that's why this term exists, non-celiac gluten sensitivity, not have these issues, but have other issues. And one of those is polyarthritis or multiple forms of arthritis. And then a gluten-free diet in many cases, and somebody will actually alleviate their arthritis. They didn't have celiac disease classically defined. Remember that, you know, it's kind of like when you're in school and you read something in a textbook and it's like what you read in the textbook doesn't really 100% match the real world. And so it's kind of like that. Celiac disease in a medical textbook is these things, right? But not every patient that has a problem with gluten matches these things at all. As a matter of fact, it's now estimated that it's not weight loss really at all. It's actually 60% of people with gluten issues actually are overweight. Same thing. Most people with gluten sensitivity don't necessarily have the GI symptomatology. They have things like joint pain, neuropathy, Hashimoto's thyroid problems, so polyendocrine problems with their endocrine organs, the organs that produce the different hormones that help regulate the body. So this particular study, again, celiac disease may be the correct diagnosis in a patient with polyarthritis. So if somebody presents with polyarthritis in a clinic, what this research study is saying is that the doctor should understand polyarthritis, you should rule out gluten as a trigger or as a cause. And so if you've been diagnosed with polyarthritis, look, I trained in the VA hospital under one of the world's renowned rheumatologists, and I can tell you this is not something I learned in the VA hospital. It is actually something I learned in the VA hospital, but it's not something that my attending physician taught me. It's something that I had to find out because I was so frustrated with the lack of care that these veterans were getting. And it's like everybody got the same drugs and nobody really ever got better. And so I started looking at diet, and it was research on celiac disease that actually led me to this type of information. You can see this study, this particular study is from 2011. So we're almost 10 years old here. This is not new information. And there's studies that date back even further, 30, 40 years, that show this same correlation. So this is just, again, I'm trying to show you examples of evidence that you need to look at this little in a strong light. So this is a study, a research study on gluten sensitivity and psoriatic arthritis. So psoriasis, which is the skin manifestation. So think of this two ways. Psoriasis, so if you've ever had kind of the inflammatory skin disorder, psoriasis is what we call it when it affects your skin. Psoriatic arthritis is what we call it when it affects your joints. in my experience, these two conditions are the same condition. They're the same thing. It's kind of like a person with a gluten problem could have a gut issue that manifests as celiac disease, but they could also have arthritis. Well, a person could also have a skin inflammatory problem. You see what I'm saying? So a lot of times, though, because medicine is a specialized entity, meaning if you have a skin inflammation, you go to a dermatologist, right? And so if you go to the dermatologist, they're not thinking about diet, they're not thinking about gut, they're not thinking about gluten. So oftentimes the treatment for this is immune suppressing creams or steroids. And so again, there's no solution in that. There's no solution, because the day you quit taking the steroid, within a matter of weeks or even a matter of days, the condition comes back if you didn't address what was actually triggering the condition. And again, I've seen thousands of people with psoriatic arthritis or psoriasis get better, right? Have this go away when they change their diet. And so what this research study is showing, you see Diet and Psoriasis Part 2, Celiac Disease and the Role of Gluten-Free Diet. Epidemiological and clinical studies suggest there's an association between psoriasis, celiac disease, and celiac disease markers. There's early evidence to suggest that a gluten-free diet benefits those with psoriasis and psoriatic arthritis. So again, research confirmation on top of what we see in our clinic. So it's not, again, it's not just me trying to tell you to go on a gluten-free diet for no reason. This next one here, high prevalence of gluten sensitivity in a cohort of patients with undifferentiated connective tissue disease. Connective tissue disease, scleroderma, okay, or sclerotic, connective tissue adhesions forming. So we believe that all patients with the diagnosis of undifferentiated connective tissue disease, aka scleroderma, especially those with a systemic sclerosis-like presentation, should be investigated for celiac disease, even in the absence of GI symptoms. The gluten-free diet should be early recommended to all patients having undifferentiated connective tissue disease and gluten sensitivity. So again, this is research showing this correlation and this connection. So my message here is, don't wait for somebody to come to you. Don't wait for your doctor to come to you and say, hey, don't wait for them to come to you and make this announcement, because they're never going to do it, is my point. It's up to you to take this information, take this video, take a screenshot right here, take that to your doctor and ask them to test you for gluten sensitivity. Rule it out, especially if you've got any form of autoimmune arthritic condition, because it is one of the most common causes of chronic arthritis of an unknown origin. And again, what's the tendency toward a doctor once you have the diagnosis? The tendency is they don't want to necessarily do anything other than treat your symptoms with drugs. The same drugs that damage your gut, the same drugs that cause malnutrition, the same drugs that cause what I like to term grainbesity or weight gain. Now, grains can cause obesity and weight gain as well. But the reality is the drugs specifically used to treat chronic inflammation, the steroids, are the most favorite. I see so many people coming to see me that have been on steroids for years. And one of the problems with steroids long-term is they lead to muscle loss. Steroids are what are known as a catabolic steroid, or I should say corticosteroids are a catabolic hormone, meaning they break down your muscle and your bone. That's why the side effect or the risk of being on these is muscle and bone loss. Now, when you lose your muscle, one of the things that happens, muscle loss shortens the muscle. And when you shorten the muscle, you compress the joint. And when you compress the joint, you inflame the joint, you irritate it. And so then you get inflammation. So the actual side effect of the thing that you're taking to reduce the pain and the inflammation is leading to the atrophy of the muscles, which leads to the shortening of the muscles, which leads to the compression of the joint, which leads to the inflammation in the cartilage, which recreates a new kind of arthritis. So there's different kinds of arthritis. There's autoimmune arthritis. See, this is when your immune system is attacking your cartilage or your joints, but then you also have degradatory arthritis, what some doctors like to call aging. I don't call it aging because aging means that everybody who ages would actually develop severe arthritis that degrades them. But that we don't see that in the aging population across the board. We see that in people who over time take polypharmacy, don't exercise, don't have good diets, don't have good lifestyles. And so these individuals end up with what their doctor's calling osteoarthritis or degradatory arthritis, but it's not because of any other reason than they're not dealing with the actual cause. So when you have this type of pattern, it can lead to a diagnosis of a different kind of arthritis, and then they're telling you, yeah, this is different than your autoimmune arthritis. You actually have two kinds of arthritis. Lucky you, right? You won the lottery. Now you have autoimmune arthritis and you have osteoarthritis or degradatory arthritis, and neither one of those things is really true if you understand this pattern. So if we look at grain, so grain consumption comes with a lot of problems. And so gluten is just one of them. And I've shown you some evidence tonight about gluten being, a major trigger factor. And I've got the total show notes for this. I think I put a link up earlier, but if you go to glutenfreesociety.org, go to the blog there, we have an entire huge article with all of these references and links. And these are things you can click on the links and you can print out the actual studies and you can take this stuff back to your doctor and have that conversation with them. We put all these resources together for you because we want you to be able to take advantage, not just watch the show and then have a conversation with your doctor, because your doctor's not going to listen to you. That's the reality. Your doctor, though, is going to listen if you put down 10 research studies in front of them and say, I want this because of this. And that's going to open that dialogue if you walk in there intelligent, but also with evidence, because I can promise you your doctor's not reading these research studies. Not unless is somebody that I personally trained. I trained thousands of doctors in my career, medical doctors, osteopaths, chiropractors, etc. But if I didn't train them, they're probably not reading about this information. They're just not really all that privy to diet and lifestyle as a source for disease. But again, going back to this, we know gluten is one of the factors in grain, but there are other things here. And so let me blow up this diagram a little bit. Let's see, is it going to let me do it? There we go. Didn't want to get bigger for me. Okay, it might be a little blurry. We're going to keep it as non-blurry as we can. So other things found in grain: heavy metals, excessive omega-6. Excess omega-6 imbalances your fatty acid ratios. Remember, too much omega-6 promotes inflammation and pain. We know that grains can cause leaky gut. I showed you that earlier. We know that grains, specifically if you have a primary grain-based diet, it's, where grain is the staple in the diet, we know that quantity of carbohydrates can create an issue, and that excessive sugar leads to changes in hormones like cortisol and insulin. We know that grains are often contaminated with mold and mycotoxin. We know that grains are contaminated with chemicals like your glyphosate. People keep asking me about glyphosate. Those of you who've been asking me about glyphosate, I probably get this question 20 times a day. Go check it out on Gluten Free Society. I did an entire interview with one of the experts on this topic. It's about an hour long, and we broke down glyphosate together in a very detailed way to give you that information. But yes, is glyphosate a problem? It sure is. And if you're eating a lot of grain, does it come with a lot of glyphosate? In most cases, yes, it does. Molds, I mentioned mycotoxins, which aren't the same thing as molds, but they're toxins that molds produce, are another aspect. Again, we got pesticides. As I mentioned, glyphosate's just one of them, but there are other pesticides like atrazine, which acts as a chemical estrogen. And then we've got a family of proteins, one in particular called ATIs, amylase trypsin inhibitors, and these proteins actually inhibit digestion, so they can shut your pancreas down and make it harder for you to digest, creating leaky gut. The bottom line is all these qualities about grain as a food, right? Which is why when I wrote No Grain, No Pain, I didn't call the book No Gluten, No Pain. I called it No Grain, No Pain, because grain comes with all of these agents. And all these agents can stoke the fires of chronic inflammation. And what happens when we're chronically inflamed? What happens? One of the primary side effects is our cortisol response goes up. So we have an increased production of cortisol. Well, I just told you, steroids cause muscle loss. Cortisol is a steroid. Now, you can either take steroids in the form of drugs, like you can inject yourself with corticosteroid in the joint or where it hurts, or you can take oral prednisone or oral steroids or cortisone. But the fact of the matter is when you take it, remember, over time, breaks down your muscle, shortens your muscle, compresses your joints, leads to inflammation. Cortisol also causes weight gain. Now, part of that weight gain is through water retention. It causes an increase in water in H2O. Excuse me. And that H2O retention, again, if you're packing 10, 15 extra pounds of water and that is around your joints, you get heavier, right? You get fatter, basically. I talked a couple of weeks ago on heart disease, and we were talking about how some people like to say, oh, I'm big and beautiful. And we were talking about, it's not about being big and beautiful, because big and beautiful means you're big and inflamed, because being obese means that you're inflamed, at least if you live in the US or if you live in an industrialized country, that's what it means. So being overweight means it's actually a visible physical clinical manifestation of inflammation. So we don't want to see this, right? This is a representation of all this happening over time, which again causes you to gain weight, causes you to retain water, causes your joints to be under more pressure, because every extra added pound on your knee joint, on your hip joint, on your neck, on your shoulders is going to increase the wear and tear of those joints, and it's going to further degrade your joints, leading to an osteotype of arthritis. So even if you started out with an autoimmune form of arthritis, you end up with an osteo form of arthritis. That joint compression and that pain, oftentimes, I don't know about you, but when I see people that have a lot of pain, they don't tend to want to go exercise. Like, they're in so much pain, they don't want to exercise their muscles or their joints because it hurts. And so they have exercise avoidance. And what does exercise avoidance lead to? Just draw a circle right back around to that. More joint compression, more pain. Okay, more weight loss. And that's why this is a cycle, right? The arrow comes right back around. Exercise avoidance leads to more muscle gain, or rather more weight gain and more muscle loss, more joint compression and pain. And until you isolate and identify this is a problem, then you don't stop this cycle. This cycle just continues on ad infinitum, and that's not a good thing. So again, if you want to break the cycle, recognize where it's coming from. Recognize the cause, celebrate the cause, don't fear the cause. So many people say, well, it's just so hard. Changing my diet is just so hard. It's not fair. Poor me. Everybody else can eat it. No, they can't. Not really. I mean, it's estimated that 40% of the U.S. population has gluten sensitivity. That's a pretty big, overwhelming quantity of individuals. And when you take into consideration the fact that 1 in 7 in America, in the U.S., has a form of autoimmune disease already, that means you're in a room full of 7 people, there's one of them there with an autoimmune disease. And you take into consideration that autoimmune disease is the #1 killer in females under the age of 65, then changing your diet is pretty easy compared to living with all the symptoms, problems of autoimmune disease, and then the drugs and the consequences of all those drugs downstream from it. So diet change, in my opinion, is a relative easy change when you consider the alternative. All right, so as promised, I told you we'd get to, the nutritional deficiencies that can lead to chronic pain. So I want to talk about some of those. So this is not intended to be a comprehensive list, but what I wanted to do was give you some really major players, because these major players, I've seen it in the clinic, have some of the greatest degrees of impact on individuals. So vitamin C. I've actually seen cases where vitamin C all by itself reduced pain in individuals. And that's just because individuals were deficient in vitamin C, and vitamin C is a very potent anti-inflammatory, and vitamin C is necessary to heal. And so some people have what's called subclinical scurvy. If you've ever heard of scurvy, it's the name of the disease state associated with vitamin C deficiency. Some people have subclinical scurvy, and subclinical scurvy can manifest as pain. And so this is one nutrient. It's very safe to take even at very high doses because your body won't let you take more than what it can handle because you'll have diarrhea before you have any kind of toxicity. So vitamin C is a bowel tolerance. So you take it to bowel tolerance. And for many people is an answer to their struggle. Vitamin B12 is one. Now B12 is where I see vitamin B12 play a major role is in people that have nerve pain. So there'll be individuals, for example, that have diseases like multiple sclerosis or transverse myelitis, that are diseases where the myelin sheath around the nerve is starting to deteriorate, and you need vitamin B12 to make the myelin. So without B12, you cannot produce the myelin sheath. And so sometimes the pain is as a result of not having adequate myelin. So B12 very important in that regard. And so if we're looking at quantities, if you're talking about quantities, well, with vitamin B12, you know, my favorite style of B12, you will, or form is methylcobalamin. It's the form the body prefers for most people. Methylcobalamin. It's an activated form of vitamin B12. And so if you suspect a vitamin B12 deficiency, you know, start somewhere in the neighborhood of 5,000 mcg. Micrograms is what that is, micrograms per day. That's kind of a starting place. Now, it's always best to have your doctor check your levels, not in your blood, but inside your cells. So your intracellular vitamin B12, because the blood can be quite misleading, the blood levels of vitamin B12. Another one that's very effective, in my experience, is vitamin B5, otherwise known as pantothenic acid. Now, this can be effective. I've seen it be effective for nerve and for joint issues. Vitamin B5 is necessary to support cortisol regulation. So remember, I was talking about cortisol earlier and how too much cortisol can create problems. Not enough cortisol can create problems. Well, one of B5's functions is in the regulation of cortisol. Same thing with vitamin C. These two actually play together to help with supporting that normalization of cortisol. And we have things like vitamin B6. Vitamin B6, and a lot of research studies show that vitamin B6 is actually very beneficial in people with autoimmune pain for a number of different reasons. Vitamin B6 is necessary to metabolize certain chemicals that can lead to pain. I talked a few weeks ago about oxalate, and said that you need vitamin B6 to metabolize oxalate. And sometimes the reason people on a high grain diet have pain is because they're over consuming foods that are high in oxalate, and oxalate crystals can actually lodge in the joint, creating like a pseudo gout or a pseudo arthritis. And you need vitamin B6 to break that oxalate down and to get it out of the body. So B6 can be helpful in that regard, but there's also a chemical called homocysteine that B12 and B6 both help to regulate. And homocysteine elevations can also contribute to nerve pain. You also need vitamin B6 to produce some of the neurochemicals. So for example, you can't make dopamine. Dopamine is one of those molecules in your body that helps you regulate perception of pain. And so low levels of dopamine will make a person more susceptible to pain when they do come across it. So dopamine, very important neurotransmitter for the regulation of pain perception. And then we have vitamin D. Well, there's a lot of research on vitamin D actually reducing pain and reducing inflammation in autoimmune disease, especially your arthritis, so like rheumatoid arthritis, right? So a lot of research on vitamin D being very effective. This is a real easy test to ask your doctor to measure. Ask your doctor to measure what's called your 25-OH-D. And if your level is less than 50, my advice would be talk to your doctor about supplementation. So therapeutically, a kind of a strong therapeutic dose of vitamin D is anywhere between 8,000 and 10,000 IU a day. Some doctors or some will tell you that it's a dangerous vitamin because it's fat soluble. I would simply say I've never yet seen the case of vitamin D toxicity in 20 years of practice using high levels of this. Now, that being said, that doesn't mean that you should just run out and take as much as you want. You should always look back to having your levels tested and not just take it indiscriminately. The best way to not need vitamin D is to get your autoimmune inflammation under control by changing your diet. Then you don't need as much vitamin D, because when you don't have autoimmunity, your body doesn't need to burn through all that vitamin D as much, so you're not as prone to developing deficiency. And the natural sunlight and then foods like mushroom and liver can take on the job of providing that for you. Quercetin, and this is one of my favorite. I love quercetin, and the reason why is quercetin has this, it acts on the same place biochemically as steroids. So when doctors give corticosteroids for pain, quercetin works on the same chemical. Vitamin C and quercetin, when given together, have a synergistic effect on the same chemical process that steroids affect. So I love quercetin. 1 to 2 grams a day can be extremely effective. And I've seen people, use quercetin and vitamin C, and again, key here is under supervision. You don't want to do this without your doctor's supervision, using vitamin C and quercetin together to be able to wean off of their steroids and stay stable and still have good function. And then we have minerals like calcium and zinc and magnesium. These are the 3 big ones, although not the only 3, but these 2 particularly, calcium and magnesium, I like to call them the lost electrolytes. They generally aren't added to electrolyte formulas, but a lot of people don't realize that magnesium and calcium regulate neurological function. And I see all the time people with chronic nerve pain as a result of calcium magnesium deficiency. I also see people are taking drugs like calcium channel blockers and diuretics that deplete these 2 nutrients, end up in a lot of pain, having a lot of acute muscle spasms. So they have a lot of muscle cramps, muscle spasms, and nerve pain as a result of depleted levels of calcium and magnesium. And then zinc as well. Zinc plays a major role as an antioxidant. And in one of its functions as an antioxidant is to help quench or stop aggressive free radical formation that damages your DNA. So it helps your body do something very well, and that's heal and repair. Zinc is critical for the healing and repair and kind of the so inflammation is normal. A lot of people demonize inflammation just as a general word. They say, oh, inflammation is bad, but the reality is inflammation is what your body uses to break down old tissue so that it can repair and build new tissue. And so you want a healthy level of inflammation, and zinc is what regulates the healing and repair around healthy inflammation. So you definitely want to make sure you have adequate zinc. And then omega-3. This is actually one of the things when I was in the VA hospital in the rheumatology department, this is one of the things that I found in the research originally was that omega-3 was equally as effective as non-steroidal anti-inflammatories according to some research studies. But the dose had to be high enough. So you really had to get upwards of 4 to 6 grams a day of omega-3 fatty acids that are concentrated EPA and DHA to have a really solid effect on inflammation. So remember, omega-3 fatty acids help regulate inflammation. Now, I talked about this a minute ago when we were talking about this right here. Remember I said that grains contain excessive omega-6? Think of omega-6 and omega-3 like, the 2 kids on the teeter-totter. There's a balance between them. And if, one kid's a fat kid and the other kid's a really skinny kid, then the skinny kid's going to be up here in the air with his legs dangling, and you don't want your omega-3 to be the skinny kid. You want there to be a nice balance between the 6 and the 3, because otherwise what you're going to do is you're going to increase and potentiate the inflammatory process. So if we're talking about supplements, these are some of my favorites. Just because their biological function is so crucial to both autoimmune regulation, but also inflammation regulation. So now I'm going to open it up for any questions that any of you have. So let's dive into those. We got a few minutes left to knock those out. Let's see, Juan, can supplementation fail to produce desired results in some people determined to have a deficiency? No, not in my experience. When supplementation fails to produce a desired result, it's not usually the supplements that are failing. It's typically an underlying problem that hasn't been fully identified or addressed. So generally, supplementation works if we know we need to supplement and we have scientifically sound, objective data that says this person needs more of this nutrient. It's not that fails. It generally, the supplementation will work, but whether or not, I think what most people think is, hey, if I'm low in B5 and I supplement with B5, does that automatically mean that my pain's going to go away? Well, not necessarily. Your pain might go away if the cause of your pain being there is a B5 deficiency. And so you have to understand that these nutrient deficiencies can cause pain, but there's a lot of causes for pain. These are just some of them. And so these are some of the more common ones that I see being the most effective and oftentimes being deficient in people with chronic autoimmune problems. So it's generally not supplementation that fails as much as it is a lack of working from all of the objective data that's necessary to help isolate and identify what the origin of the person's problem is. Let's see here. Can't comment on other people's books. What to do in case of salivary gland issue 15 years ago, radiotherapy in my neck. I wonder if it can heal without removing the gland. The first thing I would say, Sophia, is get with your doctor and have a full nutritional workup done. It's possible that, radiotherapy can be pretty harsh on the glands and you might have permanent damage. It's hard to say. But at the very least, get a full nutritional workup so that if you do have some deficiencies or things that are lacking, then you can add those into your diet and give your body every opportunity to heal. Is there a relationship between gluten sensitivity and sacralization of L5? Not to my knowledge, Donna. Sacralization of L5 is when L5 in the sacrum actually fuse, is generally what we would consider to be a congenital defect. And I haven't seen anybody research that in any great depth as it relates to gluten. Let's see. Yeah, all grains in the UK contain mold. It's our climate and the big vats they're kept in. Yeah, mold is a major problem, no doubt about it. Crohn's disease and psoriasis. A friend of mine has both of these issues, and her face gets blistered from the medicine the doctors have her on. Under her eyes, it looks like she has black eyes. Yeah, she's got to get real about root cause resolution. She can't just keep medicating the symptoms of the disease. Why does drinking water make my mouth and throat dry? It depends on the water that you're drinking. Some people drink reverse osmosis water and they're dehydrated. And RO water is great. It's the cleanest water. And if you have to drink city water, that, in my opinion, is still the cleanest water to drink. But it can be very helpful to add electrolytes back into the water when you do filter it. So if you're drinking RO water and that's the case, make sure I have something called Ultra Electrolytes. You can check it out. But add, for every 20 ounces of water, add about a half a teaspoon of that, and that should help potentially keep you better hydrated. Let's see. Let's see, gut. Oh, no, that's not a question. Is ascorbic acid true vitamin C, or is it just one of the attributes that make up whole vitamin C? It's a good question. I mean, if we're talking about the whole molecule of vitamin C, in science, we talk about all the vast science. What are the benefits of vitamin C? Then kind of vitamin C and ascorbic acid are used synonymously. But if we're talking about whole food-based vitamin C, no, not all of the components of whole food-based vitamin C are going to be in ascorbic acid. However, again, if we're talking about the research and the therapeutic effectiveness of vitamin C, most of it's done on ascorbic acid. And so that's where you're going to see differences. There's really no great research on whole plant foods-based vitamin C being more effective than ascorbic acid. Actually, most of the research is pointed at high doses of ascorbic acid being extremely effective. So some people will gravitate toward kind of some of these food-based supplements where they talk about a plant-based form of the whole aspect of vitamin C, and that's fine. You can do that. But if you really need high-dose vitamin C, ascorbic acid is where it's at. Let's see. Do you recommend curcumin for pain or boswellia for inflammation for RA? I do, but why are those not on the list? I'm so glad you asked that question. Here's why they're not on that list. They're both great. They're very potent anti-inflammatories. They have modulatory effects around inflammation and pain, and there's a lot of research on both of them. However, those compounds, boswellia and curcumin, are not essential to the diet, meaning they're not essential nutrients. My philosophy is essentiality has to come first. Okay, then we can look at plant medicines. You have to understand that curcumin and boswellia are plant medicines. The whole premise of medicine is to alter biochemically the expression of chemical outcomes in an effort to attempt to mitigate symptoms. In essence, here's something to take to reduce your symptoms. If we use boswellia and curcumin to treat pain, then we're really not finding out why the pain exists. So the same thing, doctors make mistakes, in my opinion, like this all the time, where they use aspirin to treat pain, or where they use, they use a non-steroidal anti-inflammatory or a steroid to treat pain, but they're not asking why is the pain there. To me, it's infinitely more important to ask why the pain is there than to treat it even with something natural. If you use natural agents to treat your pain, it's what we call green medicine. Okay, and there's nothing wrong with doing that if you can't figure out why the pain exists. But if you haven't even asked the question, my advice to you would be get with a good functional medicine practitioner and start asking the deeper question, which is why is the pain there in the first place? Does lead in the gut cause leaky gut? Yes, it can. There's some research studies showing that lead opens up the gut barrier and yes, definitely can cause a leaky gut issue. Are borderline vitamin nutritional deficiencies as potentially serious as deficiencies? I've heard you mention and have a few deficiencies and even more borderline. Any thoughts? Depends. That's a clinical call typically, Addie. Sometimes yes and sometimes no. And so it's hard to answer that question just based on the simplicity of it. It could be deeper than that. But generally speaking, the difference between a borderline deficiency and a functional deficiency is a functional deficiency means your cells are no longer functioning adequately. A borderline deficiency means they're close to losing their function. And in some cases, I've seen functional borderline deficiencies be just as detrimental as the major deficiency. Is dry mouth caused by IgA deficiency? No, typically dry mouth causes IgA deficiency, but not the other way around. Does my thyroid medication cause problems? I take Armor. I don't know if your thyroid medicine causes problems. That would be a conversation you'd want to ask your prescribing doctor. But as far as Armor containing any kind of gluten, last I looked, it didn't. Armor didn't contain any form of gluten. So if you're trying to follow a gluten-free diet, that, again, the best thing you can do is ask the pharmacist or look on what's called the inactive ingredients on the label of your medication. Let's see here. What's your best snack that I eat? Wow, that's kind of a general one. Best snack? Well, it depends because taste is relative, right? For me, one of my favorite snacks in a pinch is beef jerky, grass-fed beef jerky. It's a company called Nick Sticks. I think we have a link to them on Gluten Free Society under the food category. But that's one of my favorite, quick go-tos. If you're a vegetarian and that wouldn't work for you, then just generally a piece of fruit, maybe a handful of nuts, something super easy. Again, the best snack is something that you like, that you will eat when you're in a pinch, and that's easy and transportable, and it has a relatively longer shelf life. So like on my desk in my office, I keep a couple of apples, I keep a bag of almonds as a kind of a go-to in a pinch. Usually I bring my lunch with me, but sometimes you're in a rush and you get out of the house and you don't quite have what you need. And I'm a big fan of fasting when I don't have real food. So like as opposed to eating what's available, I generally will make the decision to fast instead of snacking on something that isn't good for me. Let's see. How to help compressed nerve herniations from a car accident? It's a good question, Ken. If you've got compressed nerves from disc herniations, if they're in your lumbar spine or your low back, I would suggest that you get with a good chiropractor, probably the best doctor as it relates to treating disc herniations post-MVA motor vehicle accident. There's a type of therapy a lot of chiropractors perform called spinal decompression, and can be a very, very effective along with spinal manipulation to help take pressure off the discs and off those nerves. So I get with a really solid, good chiropractor with a great reputation in your area, and maybe even inquire as to whether or not they perform spinal decompression as a therapy. Okay, let's see here. Could chronic intake of Xanax justify or worsen symptoms that suggest scalloped tongue? Well, no, not that I've ever seen. Chronic intake of Xanax, more than anything else, just robs you of your sovereignty to function. But I've never seen it or clinically made any kind of correlation between that medicine and a scalloped tongue. See, Melody says, if you take the genetic test for gluten intolerance or gluten sensitivity and it is positive, is the positive result saying you are allergic to gluten or just have the genes that would make you prone? Is it a definitive test? So Melody, yeah, so you have a really good question. Genetically, if you have the genes for gluten sensitivity, you shouldn't eat gluten. Because it does, it's a predisposition test, but it really, what predisposes you to reacting to gluten if you have gluten genes? Eating it. Right? So what activates those genes? It's kind of like if you have predisposition to diabetes, what predisposes you to developing the diabetes? Eating sugar. So it's the same thing with gluten. If you have gluten sensitivity positive genes, then the way you activate those genes to produce the inflammation is by eating or exposing them to gluten. So the way you want to look at a gluten genetic test is if you have a positive result, then the best move for you to stay healthy is to get gluten out of your diet. Whether you have celiac disease or not, whether you have autoimmune disease or not. Some people, remember, gluten-induced autoimmune disease can take decades to develop. The average person with celiac disease doesn't get a diagnosis for upwards of 30 years. It takes about 35 years on average to get a diagnosis, because most doctors don't train in nutrition and they're just not looking for nutritionally related types of situations. So you don't want to wait for 30 years of gluten-induced damage to become so severe that you finally have the ability to get a diagnosis. Remember, getting that diagnosis isn't the imperative part. Recognizing how you should change and improve your diet it is, in my opinion. Okay. I think we're out of time, folks. We got more questions coming in than what I have time to answer. But hey, look, if you've got more questions and you want to see me cover different topics, shoot me an email over at glutenology@gmail.com. Look, we're taking your topic ideas. We try to produce topics that you guys want. We certainly want to take care of you, and we want to cover things that you have great interest in. Also, make sure you come visit me at glutenfreesociety.org. We have the largest gluten-free newsletter in the world. And look, sign up for the newsletter if you're not already signed up. We'll send you a bunch of great, wonderful, free information on how to navigate the gluten-free lifestyle in an appropriate manner. So make sure you come over there and sign up. When you do, you'll get a free gluten-free survival guide to your inbox right away. We'll send that over right away. Also, make sure you subscribe to the feed and to the channel. And remember, make sure you share it. The more you share the information, the more people receive it. The more people receive it, the more we can all help together. Remember, the mission here is to save 100 million lives. So if you're part of that mission and you want to help me out, give me a love, give me a like, give me a thumbs up. Again, the more of those we get, the more of this information is shared through social media channels. So share it, and we'll see you next Monday night, again, 6 p.m., same time, same channel for another episode of Pick Dr. Osborne's Brain. Have a fantastic week. Hey, don't forget to tune in next week, same time, 6 p.m. Central Standard Time for another Pick Dr. Osborne's Brain show. Bring all your toughest health questions to me. I look forward to answering them. And before you leave today, make sure you hit subscribe. And once you do, click that bell. That bell is going to allow us to remind you right before we go live, but it's also going to allow us to remind you when we come out with other video content all week long. We've got lots of episodes coming your way all week long, and I don't want you to miss anything. So again, subscribe, hit that bell so that you can get notified when we have that new information put up for you. Thanks so much, and I'm wishing you excellent health. Have a great week. We'll see you next Monday night.